You are live now, doctor.
Good evening, everyone. On behalf of YOSI and YOSI Oculoplasty Focus Group, a very warm welcome to all of you. So YOSI Oculoplasty Focus Group is a dynamic team led by Dr. Puneet and including Dr. Nupur Goel, Dr. Ridhisha Thomas Grover, myself, Dr. Rolika, and Dr. Shruti. So ExPresYO is actually an initiative which arose from a casual conversation with Dr. Puneet and I on how every resident and fellows should be guided to present cases at national and international level, regardless of their institute or medical college. So this is a unique initiative in the sense that every presenter is guided by a mentor, which they can choose, or if that's not possible, we assign them. So making it competitive is only a secondary objective. And we have also collaborated with the YoSlides team of YOSI, which share the same vision. Now, I would like to request my co-moderator, Dr. Sumer, to introduce our expert panel of judges and kickstart the session. He is currently an oculoplastics fellow at LV Prasad Eye Institute, Hyderabad, and is actively publishing in the field of oculoplastics, including high-end journals like Orbit, Current Eye Research, and BMJ. He also has also delivered multiple scientific presentations at several conferences and is a member of the Oculoplastics Association of India as well. Over to you, Sumer.
Thank you so much for that, Ayushi. So before I introduce our expert panel, I'd like to introduce Ayushi herself. Ayushi is currently working as a consultant at Dr. Saurabh Patwardhan's Nanda Deep Eye Institute. We can move the slide, Ayushi, probably.
Yeah, just a second.
Yeah.
Yeah.
No,
it's okay. We can start with our expert panel of judges.
We have 3 expert judges today who will be helping score the contestants as well as provide their opinions on the cases. We start with Dr. Raghuraj Hegde, who is the head and senior consultant in the Orbit and Ophthalmic Plastic Surgery and Oncology Service at the Manipal Group of Hospitals in Bangalore, as well as multiple other hospitals in Bangalore. He has undergone a fellowship in the prestigious NUHS in Singapore under the mentorship of Dr. Gangadhar Sundar, and is also one of the directors of the Vision Mission, a non-for-profit organization providing eye care solutions in underprivileged parts of the world, and is an executive member of the AP Soppers and the OPI team. Next, we have the privilege of having Dr. Anita Sethi, who is the Principal Director and Head of Department of Ophthalmology at the Max Multispecialty Center and Max Super Specialty Hospital in New Delhi, and has been previously affiliated with multiple other hospitals. She has a special interest in intraocular tumors and has pioneered the use of selective IAC and plaque brachytherapy for these conditions, and also works with various NGOs, one of them being Make Love Not Scars, dedicated to acid burn survivors. She has several index publications and book chapters and has chaired several scientific sessions at the national level. She also is now the vice president-elect of the Oculoplastic Association of India. Thank you for joining us, ma'am. And thirdly, we have Dr. Namrata Adulkar, who is a consultant in oculoplasty and orbit at the Samyak Eye Clinic in Pune and a visiting faculty at the Jahangir Hospital in Pune. After completing her MBBS from the prestigious KEM Hospital in Mumbai, she underwent multiple fellowships, one of them being at the Arvind Eye Care System and International Fellowship in British Columbia, Vancouver, and the United States. She has multiple publications to her name. Thank you for joining us, ma'am.
Thank you to all our judges and mentor panel today for joining us. We'll now start with our first presentation by Dr. Palak, who's currently doing her fellowship in oculoplasty at SNC Chitrakoot under the mentorship of Dr. Narendra Patidar, who's the head of the oculoplasty and ocular oncology services at SNC Chitrakoot. Over to you, Palak. Your
Thank you, ma'am.
Presenter view right now. Yeah, we cannot see your screen now. You can share it again. We can see your screen. You can put it in slideshow mode, Dr. Palak.
Yes, ma'am.
Ma'am, I'm unable to do it.
Can you click the button on the right side of your desktop, right bottom, the slideshow icon?
Are you using Mac, Palak?
No, ma'am.
Okay, so you see the button at the bottom, right side. Keep going down, down.
Here
There's
I
a
can't see,
board.
ma'am.
There's a board sort of a thing at the bottom taskbar. Or you can see on top it's written slideshow. You can click on the slideshow on the top bar. On the top bar where it's written file, home, insert, draw, design, transitions, animation, slideshow. Yep, go to the left.
Ma'am, I'll share it again.
Okay.
Is
Yeah.
it visible now, ma'am?
Yeah, it's okay.
Please go ahead.
Okay. Good evening, everyone. First of all, I would like to extend my sincere gratitude to UC for granting me the opportunity to present on this esteemed platform. Today, I'll be presenting a case titled A Rare Case of IgG4 Related Orbital Disease in Pediatric Age Group. So, an 8-year-old female patient came to our OPD on 14th of November 2023 with the chief complaints of protrusion of left eye since last 4 months, which was gradually progressive and painless in nature. On ocular examination, right eye was within normal limit and the left eye had a vision of 6.6 with inferior displacement of 3 mm with MRD1 of plus 2 mm and increased tarsal platform show of 7 mm. Extraocular movements were full and free in all cases. On palpation of left eye, mask was soft to firm, non-compressible, non-reducible, present in the superolateral aspect of orbit. Posterior extent of the mask could not be traced. There was resistance present on retropulsion with difficult finger insinuation on superotemporal quadrant. Left eye proptosis of 5 mm was present. CECT orbit and PNS was advised to ascertain the posterior extent of mass as well as the structures involved in CT. We can see an ill-defined diffuse heterogeneous mass in preseptal and extracorneal planes of the left orbit superolaterally abutting the globe. Mass cannot be differentiated from lacrimal gland and LPS-SR complex. So based on the clinical and radiological findings, we came to a differential diagnosis of orbital inflammatory disease and RMS. Further, an incision biopsy was planned. It was taken by a lid incision. Intraoperatively, the mass was pinkish in color with soft to firm consistency, and it was sent for confirmatory histopathological diagnosis. So we had ordered the following investigations to rule out other specific causes of inflammation, which showed slightly raised ESR. To our surprise, both P ANCA and serum IgG4 came positive. Histopathological examination revealed the storiform fibrosis with lymphoid and plasma cells, which supported the diagnosis of IgG4 related orbital disease. So patient was started on NSAIDs and further IHC was advised for confirmation. On immunohistochemistry, we found the ratio of IgG4 is to IgG cells is 0.5 to 0.6 is to 1, meaning that 50 to 60% IgG4 positive cells were present. And IgG was immunoreactive in CD138 positive cells. So we came to a definitive diagnosis of left eye IgG4 related orbital disease. Patient was referred to the rheumatologist for further evaluation, and after ruling out systemic involvement, patient was started on oral corticosteroids along with calcium and vitamin D supplements. So on follow-up, at presentation in November 2023, the patient had 5 mm of left eye proptosis with an inferior displacement. After 3 months, her dystopia improved, but the proptosis remained unchanged, and her condition was slowly improving. She was started on prednisolone 15 mg. After 5 months, she visited the rheumatologist, where repeat serum IgG4 was elevated. Then she was started on azathioprine 25 milligram twice daily, along with prednisolone in a slow tapering dose. After 7 months, she returned with an increased proptosis of 6 millimeter and an inferior displacement of 1.5 millimeter. So we advised continuing the same treatment as per the rheumatologist. At 1 year follow-up in November 2024, she was started on tablet mycophenolate mofetil 500 milligram PD. At the next follow-up, 1 year, 3 months follow-up at rheumatology clinic, patients presented with decreased left eye vision and altered color perception. The fundus examination revealed left eye disc edema. So she was treated by the rheumatologist with 2 doses of rituximab and intravenous methylprednisolone 80 milligram over 1 hour to control acute inflammation. In June 2025, serum IgG4 was again done, which was within normal limit. On next follow-up on September 2025 at our OPD, on ocular examination, the left eye vision was reduced to 612 with inferior displacement of 2 millimeter. Fundus showed resolving disc edema. So patient is in constant follow-up by rheumatologist and repeat CE MRI orbit has been advised from our side to the next follow-up. Coming to discussion, IgG4-related orbital disease is a systemic fibroinflammatory disorder with an elevated IgG4, plasma cell infiltration, and fibrosis. Orbital involvement presents with painless proptosis and lacrimal gland enlargement. It's rare in children, mostly seen in adolescents. Orbital involvement occurs in approximately 14% of pediatric cases, and median age of onset is around 14 years. Studies by Jalaj et al., Tilley et al., and Toronto et al. Highlight that pediatric IgG4-related orbital disease presents with varied clinical features. The key points include diverse presentations from localized orbital disease to systemic involvement, need for early recognition, and long-term management using steroids and immunomodulators to prevent relapse. According to Karim et al., the management of pediatric IgG4-related orbital disease should include histopathological confirmation, prednisolone as a first-line therapy, steroid-sparing agents for maintenance dose, and rituximab for refractory cases. Immunomodulators such as mycophenolate mofetil, azathioprine, and methotrexate as adjuncts in selected cases. So the learning points from this case are IgG4-related orbital disease can progress slowly and cause serious complications despite treatment. Close monitoring with repeat imaging and labs along with steroids and immunomodulators or biologics is essential for effective management. And overlap with autoimmune conditions, such as in this case with positive PNCA, should be considered, requiring a broader evaluation and tailored therapy. Thank you.
Thank you, Palak. That was a very crisp presentation. I'd like to invite our judges, starting with Dr. Anita, for comments and questions.
Yeah, Dr. Palak, that was a good presentation. It's just, it's a rare case, so we should go very logically. And when you're doing your presentation, like when you gave us the description, you started off with the ptosis and the displacement. And then you went on to something else, and then you came down back to proptosis. Now, proptosis was the most important feature of this case. You should,
Yes.
start. How did you determine the proptosis? You use Hertel's
Ma'am,
or
yes, ma'am. On
you
Hertel's
should
exophthalmometry, the proptosis of 5 millimeter was present.
Yeah. So when we do a case, it's inspection, palpation, like that. So the inspection part comes first, and then you talked about touching the mass and where you could feel it. So just go in order. It
Yes,
was
sir.
sounding a little like you've not been with the case right from the beginning. Someone has given you the case history and you are presenting it like that. So it shouldn't sound like that. It should be that this is how I saw the case and I went step by step, and then I come to this differential diagnosis, and then this is what we do next. So when your case is a long serological, chronologically, you should give us all the findings. Like you said, initially there was a response, then they went to the rheumatologist. It's not very clear what is the timeline. And so when did the vision fall and why did the vision fall? That's also not clear. Why did
Ma'am,
the
vision
vision fall?
fall, ma'am, because
Hmm.
of disc edema.
So you're suspecting some optic
So,
neuritis component? What? Why would
Yes, ma'am.
the mass is nowhere near the optic nerve, so it's not pressing on the
Yes,
optic
ma'am.
nerve,
It
right?
is.
So it's
Yes,
an
ma'am.
optic neuritis or that your thing, or an optic neuropathy or something. So then some investigation should be done there, not to find out why is the disc edema there. That also needs to be mentioned in your description of the case. That because they've given steroids, it's presumed optic neuritis, so you have to write presumed optic neuritis. I mean, it has to be mentioned so that it just makes sense that why was this part done. And so, was the patient ever in remission? The patient never went into remission, right? The disease continued over this 1.5 years that you've been following.
Yes, ma'am. Uh,
Okay.
Further from the starting, the patient has little bit improvement in proptosis, and then reoccurrence happened, ma'am. The disease reoccurred. The proptosis increased.
Yeah, I mean, from what I could make out, that it never fully responded, and we got new features as well. So this is a really difficult case, and it's going to need very long-term follow-up. And because it's rare in children, IgG4 disease is rare in children, we don't have too many comparisons, but you should compare it to other cases. What is your result as compared to the literature of IgG4 disease? And if you don't have any enough studies with children, then you compare it to the adolescents or whatever is the closest age group. Is this the normal way it behaves or not? You should be able to, highlight that you've chosen this case because it was an unusual, and it even in that unusual subset, it has responded well or as expected or not as well. Yeah.
Yes, ma'am.
Thank you, ma'am. Raghu,
Yeah.
sir.
Yeah, it's a can you hear me? Yeah.
Yes, we
Yes,
can
you're
hear.
audible.
Yeah, yeah, Palak, good case for discussion. It's quite rare also. But what is the biggest learning point you've taken out of your experience of treating this case? If you get another case which is similar to this, a pediatric IgG4 disease, then you've spotted it and you've taken a biopsy, you've got a biopsy, what would you do first?
So first of all, we'll start with the examination, and then we'll
No, no. After you
see
got the diagnosis, I'm saying, how would you do the treatment? Treatment after you've got the diagnosis of a EG4 pediatric age group,
so
and
mostly it
would you treat with steroids, or would you refer to the rheumatologist at that point of time, or how else would you treat it?
so
Learning from
based
your
upon
previous
the
case, learning from the previous case.
so the first line of management is starting of corticosteroids as a first line therapy. Then will refer firstly to the rheumatologist.
Hmm. Yeah, that's it. So from what I got from your presentation was that the immunomodulation was not started early enough. So
No, sir.
IgG4 has been traditionally treated with steroids, but it is now the global trend is we do not start with steroids only. If steroids is only for the acute phase, the general trend globally is that you also start the immunomodulation early. You do not wait it, especially in a pediatric age group where the inflammation can have more worsening sequelae like vision loss, ptosis, persistent proptosis, because every episode of inflammation causes fibrosis, and fibrosis doesn't go back, so it remains there. So the storiform fibrosis that you're seeing in your the pathology, it remains there. Even if you give steroids, it just causes steroid-induced fibrosis, and then the storiform fibrosis and all that will combine, and the fibrosis stays there. So you'll have a persistent proptosis despite the treatment. Even if you start immunomodulation at a later date, you will have fibrosis. So the trend now is to biopsy the earliest, not treat every inflammation with steroids, and do the biopsy after you've got a diagnosis to start a targeted therapy. So in IgG4 related disease, right now it is rituximab is the first line therapy. It is not a second line therapy. So corticosteroids is not a first line therapy. The corticosteroids is only for the post operative period where you've taken the biopsy, and for a week or two you can give it. But once you have the diagnosis, you start off with the immunomodulation right away. So, and it is given at so the earlier you start, the less long-term sequelae that you have. So that is for me, from your case, that is the biggest learning I have got. So the next time you have a
Yes, sir.
case like this, you should start immunomodulation early. You should talk to because the problem is a lot of times that for a rheumatologist, the eye is just a small organ. So you have to show that eye is also important, and you have to push your rheumatologists to be more aggressive with it, because then they will say, okay, we'll give some steroids and we'll wait. Because at the most, what is there? There will be a recurrence. So it's your responsibility to go and push the rheumatologists to be more aggressive with their immunomodulation, especially in child.
Thank you, Raj sir. Namrata
Thank you,
ma'am,
sir.
questions and comments?
Yes, I would. Most of the points have already been covered. I would just like to make one comment. Like Anita ma'am also mentioned, it was not clear whether the patient was ever in remission. Like you have treated with steroid, followed by mycophenolate, followed by rituximab, and at the last follow-up, somewhere you were suspecting optic neuritis, but it is not clear that at any point patient was in remission. When you did the histopathology, it would be helpful to know what kind of immunohistochemistry picture was seen to really guide with the further treatment. If it is not responding to mycophenolate, it is not responding to rituximab. Also, the dose of 15 milligram that you started, ideally mention the weight so that we know whether it is an appropriate optimal dosing or not. So patient has not responded to first line, second line agents. So what exactly is going on? At this point, I would go back and revisit my diagnosis, reconsider any other possibilities that we are missing here. Also, one important point before starting any immunosuppression, be it steroid or a second line agent, always and always involve the rheumatologist and in pediatric cases, a pediatrician early on. So I never start steroids on my own before getting a approval from the physician or a pediatrician or a rheumatologist for the same. So there is the battery of tests which we always get, and getting it is the first step before even approaching immunosuppression in patients with orbital inflammation. Okay, having said that, it was a nice, crisp presentation. No, well done.
Thank you,
Thank you,
ma'am.
ma'am.
Dr. Naren, do you have any comments regarding the rheumatology and the immunosuppression part?
Am I audible?
Yes, sir, you're audible.
Yeah. So rightly pointed out a few points, like one is regarding the presentation and whether patient was in remission or not. So actually the being located in Chitrakoot, and we don't have any facility with direct consultation and direct talk with the rheumatologist. We have to refer the patient somewhere else. So she was being treated in Delhi, and the in between follow-up were with rheumatologist in Delhi, and she consulted there in Delhi also with ophthalmologist. So in between follow-up, exactly we called the patient and did the information regarding the what is going on. So that's why the biggest issue in following this patient. So she did not achieve remission till now. So in between there was recurrences and relapses, and not responding to corticosteroid, and even the second line and third line medication. She is a refractory case, and when she developed this disc edema, and also she was diagnosed elsewhere with disc edema. So we don't know exactly how whether they have advised the repeat MRI and see the other involved structure, whether it is optic neuritis or something else. So we did not know exactly what was the exact cause for optic disc edema at that point. Uh, then second, coming to the, as Raghu sir has mentioned, the biggest learning point, I think we should involve the rheumatologist at initial visit, and the sir has rightly pointed out the use of rituximab at first point. So I think when we refer the patient to rheumatologist, they have started they have advised the rituximab, but patient was not willing for undergo this medication. So that's why they refused the treatment, and they started with the mycophenolate.
Thank you so much, sir.
Thank you, sir. I'll request you to unshare Palak so the next presenter can share.
Yes.
So our next presentation is by Dr. Apurva, who is a first-year DNB resident at Ganesh Vinayak Eye Hospital in Raipur. She will be presenting the next case, which has been guided by Dr. Rohit Rao, who is a consultant in oculoplasty and anterior segment services at the Shri Ganesh Vinayak Eye Hospital in Raipur. Yeah, your presentation is visible. You can put it on slideshow now. Yeah, you can begin. It's on slideshow.
Good evening, everyone. I am Dr. Apurva, first year DNB resident at Shri Ganesh Vinayak Eye Hospital, Raipur, and my topic for presentation today is thyroid eye disease. Coming to the case, a 34-year-old male presenting to the OPD with chief complaints of a gradual protrusion of the right eye since 1 month. The patient is known smoker since past 7 years and there is no known systemic illness. So what are the clinchers that we can take from the history is, first is the age of the presentation, second is the gender, third is the habit of smoking, and fourth is the proptosis, because as we know that thyroid eye disease is the most common cause of both unilateral and bilateral proptosis. But you always have to ask the leading question to rule out the danger sign, that whether the patient has any recent onset vision loss, diplopia, any history of diabetes, any history of recent onset pain, or is there any previous history of radioactive iodine therapy. Now coming to the examination, the vision of the patient was 6/6 and N6 in both the eyes. And on the inspection, we can see that there is bilateral lid retraction, but it was more prominent in the right eye than the left eye. And also there is right eye axial proptosis. Other than that, there was no abnormal head posture, no facial asymmetry, no signs of periorbital inflammation, and all the extraocular movements were full, free and painless. Now coming to the thyroid eye disease signs, there are n number of signs that we can see in thyroid eye disease. So some are documented in this case as well. First was the Dalrymple sign, in which we can see that there is asymmetric eyelid retraction with lateral flare that is present in both the eyes and prominent in the right eye than the left eye. Second is the von Griffith sign, in which we can see when the patient is asked to look in the downward gaze, there was lid lag that was present and seen in the right eye. In this video, we can see that when the patient was asked to close the eyelid, there was fine tremors of the lid that we can appreciate. This is known as the Rosenberg sign. Next is the characteristic angry looking appearance of the thyroid eye disease patient, which is known as the staring appearance or the Kocher sign. Fifth, when the patient is asked to maintain the eye in convergence, there is inability to maintain the convergence, which is known as the Mobius sign. And also, if the patient is asked to look in the upward gaze, there is a lower lid lag, which is known as the Griffith sign. And we can here see that there is increased scleral show on the upward gaze, which is mean sign. Last but not the least, when the patient is asked for the blinking, there is incomplete blinking, and also the frequency of the blinking is decreased in the thyroid eye disease patient. Now coming to the measurement of the lid retraction, the MRD1 and MRD2 both were increased in both the eyes. Also, the exophthalmometer findings in right eye was 18 mm and the left eye was 15 mm, done with Hertel exophthalmometer reading with base 100. On the slit lamp examination, all the anterior segment findings were within normal limits, but you should always keep in mind to look for any temporal conjunctival congestion, always look for scleral show, and you should evaluate the cornea to rule out exposure keratopathy, and always look for relative efferent pupillary defect to rule out optic nerve involvement in the thyroid eye disease. Also, there can be a early onset cataract in the thyroid eye disease patient because of the prolonged use of steroids. In the fundus examination in both the eyes, fundus examination was within normal limits. The IOP in both the eye was 10 mm of mercury and the Schirmers were 35 mm and TBUT was more than 10 seconds. So on the basis of the history and the examination, we can come to the clinical diagnosis of the thyroid eye disease, which is itself sufficient, but we should always keep in mind the serious differential diagnosis of thyroid eye disease, that is any orbital mass, carotid cavernous fistula, orbital mets or pleomorphic adenoma. Now coming to the activity assessment of the disease. First, the CAS scoring was done for the patient and it was 0 for both the eyes, therefore the bilateral inactive thyroid eye disease. Also, the modification of the CAS classification, that is UGOGU classification, it came under the mild classification. Coming to the management part, in the investigation, there are a number of investigations that can be done in the patient, but in our patient, we did the thyroid function test. So the T3, T4 level was raised in the patient and the TSH level was decreased, which was pointing towards hyperthyroidism. So on the basis of first the history and then the examination and then correlating it with the thyroid profile of the patient, the diagnosis of the patient was hyperthyroidism with bilateral mild thyroid eye disease. And then in the treatment, first and foremost, we have to ask the patient about quitting smoking. It is the most important exogenous modifiable risk factor for the thyroid eye disease and progression of the disease. Second is the eye drops for the symptomatic relief of the patient. And third, patient was advised for supratarsal triamcinolone injection for the lid retraction. But as of now, patient did not wanted any invasive procedure. And fourth is the endocrinologist opinion. So the take-home message from the presentation is that in every case of thyroid eye disease, first and foremost, we have to assess the disease activity via various scores to first further prognosticate the disease and plan the treatment protocol. Second is the keeping check in the level of thyroid hormone levels. Though euthyroid patient can also present as thyroid eye disease, but they can later on become hyperthyroid or hyperthyroid or hypothyroid. So regular thyroid hormone level should be kept in check. And third is the need of multidisciplinary approach. That is, we should work in conjunction with the endocrinologist throughout the case so that we can halt the progression of the disease and avoid ups and downs that are coming in the disease progression. Thank you.
Thank you so much, Dr. Apurva, and congratulations to you, a first-year resident talking about clinical activity score in supratarsal triamcinolone is really commendable. I would now request Dr. Namrata and Dr. Raghuraj to ask her a few questions and their comments. You can unshare your screen, Dr. Apurva. Yes, Dr. Namrata.
So yes, very nicely presented, Apurva, and congratulations. Being a first year, you have very nicely demonstrated all signs of, especially the eyelid signs of thyroid eye disease very well. Yes, and I agree with you. This is an inactive patient with thyroid eye disease. However, some more when you are starting with history taking in patients with TED, negative history comes in a long way. Like you need to mention if there is any. Did you ask for diplopia? Was it there, not there? With a patient who, when you examined him, there is so much of limitation. Definitely IR is involved. Maybe some amount of SR involvement is also there. And no point you showed us any imaging photos in this whole presentation. So all these things are important. Always mention negative history. That will help you, diagnosis whether it is a new onset upper eyelid retraction is still considered as an sign of activity, on clinical presentation. Any patient with new onset upper eyelid retraction, which is so severe, we would just not treat him with lubricants. I would go ahead and get his antibody titers done to find out if there is any activity there. If the levels are raised, I would still go ahead and treat him with immunosuppression.
Yes,
Okay. Another thing was, yes, any patient you will document with a visual field test. You should have baseline measurements because you know that it is not a one-time disease. It's a progressive condition. The
yes,
progressive orbital disease. So you should keep all your optic nerve tests in place. So color vision, pupillary examination, fundus examination, all those things I found missing in your examination of the case. Then go ahead with getting visual fields done to, find out if there is any compromise there. Motility, there was nowhere it was mentioned whether there was limitation of movement. Also cover test, because I thought the patient did have some hypotropia in that eye. You saw in the first picture in the primary gaze, the lower eyelid the scleral show was absent. The lower eyelid was above the level of the limbus. So all these are finer points. You did a very good job for a first year, but definitely there is scope for improvement.
Thank you, ma'am.
Thank you, Dr. Namrata, for your constructive comments. Dr. Raghu, do you have any questions or comments for her?
Yeah, I agree with Dr. Namrata about the his taking and the lot of details were missing. One question I can ask is what is the Rundle curve?
The Randall curve is basically about the disease progression and then the activity of the disease. First, it from the inactive phase it gets into the active phase, and then again remission occurs. But the halting process that is there, still there is some, even if there is improvement, it does not come to complete improvement. Still there is a difference in the initial phase and in the final regressive phase of the patient. That is what described by the Randall's curve.
Okay, so of course, not all the cases will follow the Rundle curve very religiously, but when you are giving corticosteroids, which would be the best time to start corticosteroids, and which would be the best time to do surgery? At the start of the Rundle curve or at the end of the Rundle curve?
At the end of the Randall curve.
The steroids?
No, sir, the
Corti-
surgery. The surgery
So
should be at
corticosteroids, when would you start?
Sir, I don't.
So corticosteroids, you would start at the beginning of the Rundle curve because the reason for your corticosteroids is not for your not for the cure of the disease. It is to limit the damage that is caused by the inflammatory reaction.
Yes.
So whatever damage, the fibrosis, all of the things which are there, you want to limit that damage. That is why you give it in a weekly manner or in a protocol based manner, so that you don't overwhelm the body with a lot of steroids, as well as you have to control the disease as well, and you have to give it over a long period of time. So the dosage is usually moderated in the there are different protocols being followed, but usually the most common protocol is this 6 weekly protocol, that with 6 weeks, 6 weeks, 6 weeks of 500 mg of IVMP weekly, and another 6 weeks of 250 mg of IVMP for another 6 weeks. So this is usually the regular protocol. And now, with according to the latest UGOGO recommendations, at the fourth cycle itself, you start mycophenolate mofetil, so that you can have better control over the inflammation. Surgery is always started after the inactive stage. So you
Yes.
always have to, at the end of the Rundle's curve, when you see it's a clinical diagnosis. So clinically you see there is not much activity, and then after you wait for up to 3 months to see if there any change in the parameters like proptosis, retraction, all those things. And if there has been new symptoms, then you go in the rehabilitation mode. That is your uh, decompression, your eyelid retraction repair, all of those things. You do it at the after the active phase is over. It's in the inactive phase. But in some cases where there is a risk for compressive optic neuropathy, you go in at the active phase itself and do the decompression. But that is not a rehabilitation reason. You'd go in there to save the optic nerve.
Thank you, sir.
Thank you so much, sir, for teaching and your constructive comments. Dr. Anita, do you have any comments?
I think it's all been said, and just congratulations, Dr. Purva. You did a great job for first year. But yes, you need to stress a little bit more on the investigations. I know CT scan, these are the radiological is expensive, but these are really important because this is not a one-time disease. This is a long-term disease. And we would need to know what is our baseline so that we can also later on, figure out which part of the treatment is working. And secondly, what Dr. Namrata said about the optic nerve, that is really important because that forms a direct, if there is any subtle signs also of optic nerve involvement, that's an indication for surgery, that's an indication for urgent management. So it's very important to, in the fields and the color vision must, and the pupil signs must be mentioned in all your presentations.
Thank you, ma'am. Thank you, Dr. Apurva and Dr. Rohit, for mentoring her and pushing her for the presentation. Do you have any comments, Dr. Rohit?
Regarding the radiological investigation, we thought that the patient is in inactive phase. So we went ahead with the endocrinologist opinion, and then we were following the patient. We are still following the patient. So I think that is one thing missing. And next time onwards, we'll do the visual fields also. Thank you.
Thank you, sir. We move on.
One last comment. So even in the inactive phase also, CT scan gives you valuable insight as to what kind of proptosis it is. So is it a fat dominant proptosis, or is it a muscle dominant proptosis? So that will give you information whether doing a decompression will actually reduce the proptosis or not. Because only a fat dominant one will give you a good decompression, aesthetic decompression, where the proptosis actually comes down. Because if it's muscle dominant, usually there's not much movement, so you will not have that kind of improvement.
Thank you.
Thank you so
Thank you
much.
for your comments. Before I introduce the next speaker, I want to congratulate Apurva on highlighting every sign that we read in the textbook. That was really nice that you correlated clinically, and I think we all got a revision of what these signs were called. Next, I'd like to invite Dr. Aishwarya to share her screen for the next presentation. She is currently a DNB resident at the Comtrust Eye Hospital in Calicut, Kerala. And her guide for this presentation is Dr. Anju Chandran, who is a consultant in oculoplasty and orbit services there, and also the academic director of the Comtrust Eye Hospital. We can see your screen, Aishwarya. Just put it on slide share and you can begin.
Yes, sir. Good evening. Today we'll have a presentation on when the unexpected muscle into the muscle. I'm Dr. Aishwarya Patel, DNB resident, Comtrust Eye Hospital, Calicut, and my mentor is Dr. V. Anju Chandran, consultant oculoplastic surgeon, Comtrust Eye Hospital, Calicut. So, 56-year-old male presented with complaints of gradual painless prominence of the left eye of 2 years duration and incidence dropping of the left eye upper lid for 1 year duration. He was initially evaluated elsewhere, was diagnosed as orbital myositis after radiological imaging, and was started on corticosteroids by the rheumatologist. There was no history of any thyroid disorder, ocular surgeries, or any trauma. Apart from hypertension and diabetes mellitus, his medical history is unremarkable. General and systemic examination was within normal limits. There was no regional lymphadenopathy. Head posture was normal. Best-corrected visual acuity was 6.6 and N6 in the right eye, 6.6 parts and N6 in the left eye. Pupil was round, reactive to direct and consensual light reflexes, suggesting that optic nerve function was intact bilaterally. Extraocular motility testing showed movements were full and free in the right eye, while in left eye there was a mild limitation of -1 in adduction, while rest of the movements were full and free, pointing towards an early involvement of medial rectus or a subtle restrictive or neurological involvement. On examination, there was a pinkish subconjunctival mass of approximately 1 centimeter near the insertion of the left medial rectus muscle in the interpalpebral region. It was an oval, firm, smooth, non-tender mass. There was no retrobulbar resistance and there was no change with Valsalva manner. There was an axial proptosis of 3 millimeters in the left eye and an apparent ptosis of 2 millimeters in the left eye. Rest of the anterior and posterior segment examination was within normal limits in both eyes. Routine blood workup and peripheral smear was within normal limits. So we went ahead with the radiological imaging since the initial probable diagnosis was orbital myositis and there was no improvement with corticosteroids. So MRI showed fusiform enlargement of the left medial rectus involving the tendon. There was no bony erosion or any calcification. We compared it with the CT scan, which was taken 2 years back, which also showed fusiform enlargement of the left medial rectus, and there was no significant interval change between both these scans even after treatment with corticosteroids. So our next plan was incisional biopsy. We went ahead with an incisional biopsy. When a fornix-based conjunctival incision was put, it revealed a pinkish salmon-colored patch at the insertion of the left medial rectus, and on teasing out the lesion, it was found to be extending beneath the muscle. So we biopsied the lesion and sent for histopathological examination. Sections studied showed diffuse sheets and aggregates of small lymphoid cells with round to oval nuclei with scanty cytoplasm, which were arranged around hyalinized blood vessels in a perivascular cuffing pattern. Immunohistochemistry showed staining positivity for CD20 and BCL2. It was negative for CD3, CD5, CD23, BCL6, and SOX11. So we came to a diagnosis of extranodal marginal zone B-cell orbital lymphoma, which is the most common orbital lymphoma. A PET-CT scan was taken to rule out for staging and to rule out any secondaries or primaries elsewhere. This showed an FDG avid bulky left medial rectus muscle consistent with lymphomatous pathology with no primaries or secondaries elsewhere. The patient is currently undergoing orbital radiotherapy under medical oncologist guidance with a total prescribed dose of 24 gray to be delivered in 12 fractions. So ocular adnexal lymphoma may occur in the conjunctiva, lacrimal apparatus, eyelid, or orbit. It accounts for about 6 to 8% of orbital and 10 to 15% of adnexal tumors. Extraocular muscle lymphomas are rare, less than 0.2 to 9.6% of orbital lymphomas. They usually present with painless proptosis, periorbital swelling, ptosis, diplopia, extraocular movement restriction, and a characteristic lesion is conjunctival Salmon-Patch sign. Most common histological variant is extranodal marginal zone B-cell lymphoma. On imaging, lymphoma shows on MRI, there is fusiform enlargement of the muscle, including tendon, most commonly involving a single extraocular muscle unilaterally. On CT scan, it shows homogeneous isodense soft tissue with no calcification or bony destruction. External beam radiotherapy is the mainstay of treatment for mild cases, and chemotherapy has the CHOP regimen, cyclophosphamide, doxorubicin, vincristine, and prednisolone, or R-CHOP with rituximab for disseminated cases. Localized low-grade lymphoma has excellent prognosis with more than 90% 5-year survival rate and more than 95% local control after radiotherapy. So what we learned from this case is that when a patient presents with proptosis, painless enlargement of extraocular muscles with absence of associated eye signs, the first differentials that we think of are idiopathic orbital inflammatory disease and thyroid orbitopathy. But one should also keep in mind extraocular lymphoma and orbital metastasis before concluding a diagnosis. Thank you.
Thank you so much.
Aishwarya.
Yeah.
That was a great presentation and a very well managed case. I'd like to invite Dr. Namrata and Dr. Anita for their comments.
Yes, congratulations, Aishwarya. Very well managed and well documented case, I must say. That was a good catch. The medial lesion. Yeah. So I think more or less you have done everything as per the protocol, how it should be done, and beautifully documented it. Nice, crisp, precise presentation. So well done. The only thing I found missing was the immunohistochemistry. Any patient with orbital tumor, especially if the patient is able to afford immunohistochemistry, yes, it should be done. Especially when you have a diagnosis of lymphoma, it will help navigate through future further treatment options. Now, this patient has responded. I hope he has responded to radiation because there's no follow up.
He hasn't come for follow-up yet, but over call he has said there is improvement as said by his medical oncologist.
Okay, so did they get a CT after treatment or like an MRI or a
They
PET
just
CT?
completed treatment now. They have
Okay.
to be coming soon
Okay.
for follow-up.
Okay, so yes, so if the patient had not responded to radiation or had any other systemic involvement which may have been picked up on a PET CT, we would have needed a systemic chemo regime for this patient, and that really IHC really helps to guide us through that those treatment options. Having said that, I think it was nicely done.
Thank you, madam.
Thank you
Yes,
for
I agree with Dr. Amrita. It's very nicely presented, Dr. Aishwarya, and congratulations. You've really done a very good job. And these are not easy cases to either diagnose or manage. And, they just go into this bucket of pseudotumor and then everybody's wondering. So that was a good pick. You said the previous CT was 2 years old. So the patient had been following with you for 2 years before
No,
you did the
madam.
biopsy.
Initially, they were treated at an outside hospital under the guidance of
Okay.
a rheumatologist. So
Achha.
he came here only recently. And so we
Oh, so
took an
they
MRI.
they had the diagnosis earlier. The rheumatologist knew that.
Rheumatologist thought it was orbital myositis, and corticosteroids
Okay.
was given to the patient initially. So there was a
Okay.
very mild response initially, but then he had persistence of symptoms, so he came to us.
Okay. Very well managed. Congratulations.
Thank you.
Aishwarya, I'll request you to stop sharing, and meanwhile we can have Raghu sir with his comments.
Yeah. Yeah, very good case and very well presented. And also, it highlights that the importance of biopsy, doing a biopsy whenever we first encounter something suspicious. Also, even lymphomas will also respond to steroids initially, but now it not completely resolve, but at least it'll give the effect that it is responding to the steroids. So that actually gives us a wrong direction of the way, okay, we think that it is responding to the corticosteroids, so it must be an inflammatory disorder. Another one thing, one comment is, what situation would you consider a systemic chemotherapy in a lymphoma?
Systemic chemotherapy, when there is any, according to Ann Arbor staging, for stage 1 and 2, we can consider external beam radiotherapy. If there is a disseminated disease and all, we can go for chemotherapy. Also, if there's in case of relapse and all, we can go for rituximab monotherapy.
Good. Good. Yeah. Very well
Dr.
presented.
Anju, comments from your end, and also you have trained her exceptionally well. I cannot believe this is a DNB resident who is answering questions on treating systemic lymphoma. So wonderful.
Thank you so much.
Dr. Anju, I wanted to ask you, whenever we take a muscle biopsy, what are the considerations that we should do? Like normally, if you're doing a biopsy of the muscle.
So in this particular case, I had also shown the patient to my corresponding squid surgeon too. So I had them as a backup and very gentle handling, especially of the conjunctiva. And once I was under the conjunctiva, I didn't have to actually dissect the T-node. The mass was sitting right there, so it made my job easier. And yes, though we were tempted to go beyond the muscle to look for the mass further, I just took sufficient amount of the tissue to send for histopathology, and immunohistochemistry was done. I think it was there in the slides.
Okay, thank you so
Yeah.
much, Dr. Anju. I wanted to ask the panelists about, they also say that you should stop steroids when you are suspecting lymphoma just before the biopsy. So what is the duration that you prefer? Dr. Raghu, would you like to answer that?
I actually don't give any steroids to any patient. So I
And
go,
suppose they have come, because in this case also they came
so if they come from elsewhere, I stop for at least 2 weeks.
2 weeks.
At least 2 weeks before I do a biopsy, because then it will disturb the
Right.
process. So you'll give a mixed, and you may not even get a representative sample.
Positive.
So
Yeah.
I would stop at least for 2 weeks before we plan for a biopsy.
Dr. Anita, do you do
Yeah,
the same
I
or-
agree. 2 to 3 weeks at least. And as Dr. Anju said, in all orbital biopsies, we have to be really very, very careful that we are getting a representative sample and make sure that we get sufficient sample and from the center of the mass wherever possible, because especially in a suspected lymphoma, there can be just an inflammation. If you go superficial, you only get the inflammation. You may not get the actual the diagnosis. So it must be a representative sample.
It has to be multi-layered. So you go for the
Yes.
surface, then the deep layer as well, and then you send them separately so that the pathologist knows where the actual tissue is. And
Yeah.
then there are many times then when it is in a state of transition from, say, benign lymphoid hyperplasia to a lymphoma, then you will be in transition. So that if you take it from the surface, you might actually get only the benign version of the tumor, but actually deeper, it is actually starting to form a lymphoma.
Yeah, like they say, 3-level biopsy should be taken in all cases.
Yeah, agreed. Now we'll move on to our last case of the day, last but not the least, by Dr. Yamini Maniktala, who's currently a fellow in ophthalmic plastic surgery services at LV Prasad Eye Institute. Her case is co-managed by Dr. Tarjini Dave, and she's being mentored by Dr. Shruti RS, who's currently a consultant at Giridhar Eye Institute in Oculoplasty, Kerala. Over to you, Dr. Yamini.
Good evening, everyone. So I'll be talking about orbital decompression in thyroid eye disease. Thyroid eye disease is an autoimmune condition targeting thyroid orbit, skin, and presenting with orbital inflammation of the fat and extraocular muscle, running through the active, plateau, and burnout phases with variable presentation, being it fat predominant, muscle predominant, or a mixed variety. While largely a cosmetic concern, it can be a vision-threatening condition and requiring conservative or surgical management or a combination of both. Indication for which is most commonly being a compressive optic neuropathy, exposure keratopathy, and cosmesis. So with all this in mind, whenever we plan to go ahead with the surgery in such patients, the baseline preoperative planning is most importantly goes towards doing an imaging, which is a CT scan, and also to differentiate the type of disease and preoperative planning to be done that how the case should be approached, where the most important role is being played by the imaging, where a CT scan is being ordered. So how does it help in preoperative planning is what we can see is a mid-orbital axial scan with a horizontal and a vertical line in between passing along the lateral zygomatic and a vertical line from cornea to the interzygomatic arch, give it a preoperative assessment of the relative proptosis. The second mid-coronal section has been showing, helping the bulkiness and the thickness of the muscles, with which we can come to a conclusive of what is the thickness of the muscle. A Barrett muscle index can be evaluated, and a compressive optic neuropathy can be evaluated. In the subsequent images, what you can see is the anatomical locations, intraorbital grooves, small ethmoids, and a high skull base and thickness of the floor or of the lateral wall. So with all these, in a preoperative phase, we can come to an understanding that how a case should be proceed while taking the surgery, how much reduction we can estimate in a preoperative phase in proptosis. So with this baseline understanding, I will come to my case where a 24-year-old male presented with a both eye proptosis and a history of hyperthyroidism since 3 years. He was a chronic smoker, was on abstinence since past 2 years, and taken a course of 2 course of Ugogo IVMP protocol has been taken in the past. Presenting with both eyes of having 20/20 vision, color vision was normal, right eye lower lid entropion was there with retraction as well, and an increased scleral show in right eye more than the left eye. Also, there's a 4 mm lag of thalamus in the both eye, and extraocular muscle restrictions were there, most in the elevation and -2 in rest of the other cases. So with this baseline, what we could classify it as is a both eye severe TED, and it's a timeline-wise an inactive disease with a CAS score of 1/7. And imaging was requested in this patient, and what you can see in the first image of an axial scan showing a relative proptosis in the right eye with thickened bellies. And in the coronal scan, what we can appreciate is the muscle as well as fat effacement is there. In bone window, what we can see that there's a high lying skull base with roomy ethmoids, and there's a suboptimal thickening of the lateral wall. The parasitical scan is showing us that there's a hypodensities along with a thickened belly, which is suggestive of deposition of glycosamine glycan, which suggestive of a disease being having a chronic course. So with a baseline understanding of disease activity, patient's primary complaint, and adjunctive help of imaging, patient was planned for sequential orbital decompression, right eye 3 wall, along with fat, followed by left eye 3 wall with fat, and right eye entropion correction at 1 month interval. So this is the image of a right eye 3 wall decompression along with fat, and you can see there's a significant reduction in the proptosis in the right eye in the Worm's view, whereas this is post-operatively 1 month of the left eye, where left eye decompression was done of 3 wall along with an entropion correction. This is 5 month post-operative image, and we can what we can appreciate is there's a significant reduction in the proptosis from 28 and 27 respectively in the pre-operative period to 20 mm in both eye. And the goal of expanding the orbital space, widening the orbital cavity, and removing the excessive fat and keeping the vision safe of the patient and giving the required cosmesis, and to address the diplopia which patient had a complaint was adequately provided to the patient. With this, The first wall, whenever we address an orbital decompression, is being fat, especially in mild cases, since it's the safest and least destructive option. And when proptosis being moderate, we move to the lateral wall, which not only reduces bulging effectively, but also help minimizing the post-operative strabismus and avoid sinus-related complications. In moderate proptosis, a lateral wall can be combined with a medial wall, which gives more of a balanced decompression, depending upon how much is the proptosis. And when a balanced decompression done, the outcomes are uh, much better, and more of a symmetry can be achieved. Whereas when there's a severe proptosis, the balanced decompression of medial and lateral wall is combined with the floor, which sometimes can lead to unbalanced decompression and can produce post-operative diplopia. But that's what we aim to do when there's a severe proptosis of more than 26 millimeters. So the take-home message from this I would like to address is that no one-size decompression fits all the patients. It's always a customized approach, which helps in managing such cases. For mild cases, just 2 mm of proptosis, a simple fat decompression through a transconjunctival approach is usually enough. And as the bulging increases of 2 to 4 millimeter, a medial wall helps. Sometimes a lateral wall helps, depending upon patient to patient. Moderate decompression, moderate proptosis of 4 to 6 mm, a deep lateral or a balanced decompression is helpful. And if it's a severe case of 6 to 8 millimeter, then we go for a 3-wall decompression combined with most of the time combined with a fat to provide and achieve and meaningful corrections in such patients. Thank you.
Thank you so much, Dr. Yamini. I would now request Dr. Anita and Dr. Namrata for their questions and comments.
Yeah, that was a really wonderful presentation. I think you really covered the whole topic very nicely, Dr. Yamini. So congratulations for that. So I'm just, you did a 3-wall decompression for this patient?
Yes, ma'am. 3-wall along with fat decompression.
Okay, so just tell us what were the points, why did you choose 3-wall just in this particular case? And how did you do it?
So patient has the proptosis of 28 and 27 millimeter, which baseline, which is taken as 21 millimeters, so approximately 6 to 7 mm, falling into a category of severe proptosis first. Patient second was an inactive disease and was one of his concerns. So we took a 3-wall, starting from the medial wall, decompression by a transcaruncular approach is being done, and along with the floor, and then a deep lateral wall decompression is also being done. Approximately 1.5 mm target of decompression is targeted with the fat, and the rest of the decompression has been achieved with the walls. The maximum reduction is been achieved with the lateral wall. There was a suboptimal thickening, and the main target reduction was targeted towards the lateral maximum compression with the lateral.
And you didn't have
eyes.
any.
And in the second sitting, when we're doing the left eye, we also address the
entropion.
Sorry, I couldn't hear you, ma'am.
We
had entropion in the right eye, which we addressed in the second sitting.
Okay, because the picture you showed us had the entropion switches in the left eye, so I was just wondering. What was the cause of the entropion? Can you hear me?
Presented with the entropion in the very first visit. Yes.
Okay. Because usually when the eyeball goes back, the entropion should have got corrected. So I was just wondering that did you need to do?
So it was in. Yes, so when we were doing the decompression of the right eye, we did not do the entropion correction. Post 1 month after the decompression of the other eye, when the entropion was persistent, then we addressed the entropion, not on the same sitting with decompression.
And you didn't have any damage to the infraorbital nerve or anything like that. Did you try to?
No.
How did you avoid that damage?
So while dissecting with the periorbital dissection is being done according to the anatomical landmark, as we could see in both the eyes, the location of the infraorbital groove was on the more lateral side. So it was being identified when we were going through it. And we made sure that with the DMARS and the malleable retractor that we have made sure that we are not damaging the nerve while reducing the thickness of the floor.
Yeah, and you also need to be careful of the strut over there. So
Yes.
these should be done carefully and under direct vision. Yeah, I think it was
Yes.
a very good presentation. So, Dr. Raghu, over to you.
Yeah. So, what kind of so you said mullerectomy was done at the first instance, sir, along with the decompression?
No, mullerectomy was not done.
Mullerectomy was not done. Okay. So, this is mainly a
First region
muscle
for the
muscle
first
dominant
vessel.
disease,
Yes,
right?
more of a
Yeah.
muscle, but with a fat component was also there.
So, how much of the this thing was you achieved?
There was
How
7
much
mm in the right
progress
eye
was?
and 7 mm in the right eye and 6 mm in the left eye. We achieved both 7 and 6 in both the eyes. At 5 months post-operative, there was a reduction. We achieved 20 mm at 5 months was there.
Okay. Yeah, well present. I think Dr. Anita has asked all the relevant questions, so I don't have any questions. Namrata, do you?
Yamini, I would like to ask one question here. What is the usual, why did you choose a sequential decompression one? And what is the usual duration between the two eyes that you follow?
Ma'am, generally, if it is not a dysthyroid optic neuropathy, we don't do a both eye decompression in the same setting. If it's not a visually disabilitating patient is in an active phase, and going for the both eye in the same setting was not a likable option. And in this patient, we did at a 1 month interval. So on the consecutive follow-up after 3 weeks when the patient presented, he was comfortable and well. Reduction was noticed in the right eye. So we planned the other eye in at the 4-week interval.
Okay. Was any steroids given in the postoperative period after the first decompression, first eye decompression?
No, just immediately on the first and second day, we give a bolus of stat IV Dexa is being given in the immediate post-operative period when the patient is being kept admitted for a day, and that's all. Then otherwise it's not given. So when the patient presented to us in January 2025, before coming to us 1 month back, he took a UGO protocol elsewhere, and then he came to us. In post-operatively, the mostly 6 milligram or 8 milligram, depending upon the weight of the patient, we give Dexa. Dexa is being given, not a complete course if it is not in the active phase. If the patient was in active phase, like if it's in dysthyroid optic neuropathy, then we do give, depending upon what is the presentation of the first post-operative day.
Okay.
Thank you so much.
One more comment also, because regarding the Y sequential, I think main thing was if it was a 3-watt decompression on both sides, the duration of surgery will be very large. So it would just extend, and also recovery recovery after a patient who has been operated for thyroid eye disease is more than the average person who has an orbital surgery. The lymphedema goes on for forever almost. So, and also having a second surgery will give us, if we have undercorrected the decompression, we can actually, in the second instance, when you're doing the surgery, you can actually do a little bit of the topping up of the decompression in the second surgery. So those are the advantages of doing it sequentially.
Thank you, sir. Thank you, everyone, for the valuable points. Before we conclude this session, Dr. Sumer wants to make an announcement. So we had this orbit session on 10th of August, where we had 4 presenters and esteemed panelists, including an international faculty. And now we would like to announce the winners. Over to you, Dr. Sumer.
Thanks, Ayushi. So our winners for the previous session, in third place, we have Dr. Ashwita, who is a fellow currently at Center for Sight, and she presented an interesting case on Cox or SALS. This was moderated by Dr. Rolika. In the second position, we have Dr. Neha, who is a FACO fellow and was mentored by our own Ayushi Agarwal. and she won the second place for her presentation on an interesting case of wooden foreign body. The winner of last time's session is Dr. Himani Thakur, who is currently a senior resident at the RP Center. And her mentor was Dr. Sahil Agarwal, and she presented a very rare case of a yolk sac tumor in the orbit. So congratulations to all the three winners.
Thank you so much. Congratulations to all the winners. So we have Dr. Sahil here, who's continuing the streak of winning the case presentations. Dr. Sahil, do you have any comments?
I mean, thank you so much. I mean, it's all about what Yoshi has done and bringing this juniors, giving chances to residents and fellows right there to present across the globe. Thank you so much, Ayushi and the team.
What is the formula you have to tell?
I mean, it's nothing. just, I mean, just keeping on doing what we're doing, sir, and learning from you all.
Thank you, sir. Before we conclude this session, we'll take a signature Yosi picture, followed by a vote of thanks from Sumer, as I believe Dr. Anita has to leave for a commitment. So we'll take a picture. So I would request everyone to make this Yo sign. Rest of the participants can also switch on their camera. Dr. Vaishali, Dr. Muskan, Dr. Fatima, Dr. Anurag, and Dr. Leela. Okay, I'm taking the picture now. Thank you everyone. Sumer, do you have any closing comments?
Thank you so much, everyone. I'd like to begin the vote of thanks. Before we thank anyone, we should thank Team Yosi, the governing council, and the team which is led by the oculoplasty team, which is led by Dr. Puneet Jain. Its members who are actively taking these positive initiatives, Ayushi, Rolika, and everyone else in the team. So people who are in their residency get an opportunity to present in front of esteemed panelists. Our judges, Dr. Anita, Dr. Namrata, and Dr. Raguraj, thank you so much for taking out the time. This is a very unique opportunity you give residents to learn from you all, because we know the exposure to oculoplasty is limited in residency, and they get a unique insight into what this specialty offers them. I'd also like to thank our presenters and our mentors and guides. Without them, it would not be possible. The guides have really had tireless nights, shaping these presentations into the form they are. Finally, the audience and the technical team. Thank you so much, Manjula ji, and for making this a seamless process. The audience as well. Without you all, this would not be worth it. So thank you so much. Ayushi, I think we can close the session, and maybe an announcement with Dr. Anita wants to say something.
Yeah. Thank you all for inviting me to this session. This is the first time I've seen a session like this. And really, congratulations to all of you. This is really a very nice session. The presentations were excellent. The DNB students first year, and I don't know which one Dr. Aishwarya was, but really excellent presentation, such good learning for all the students. So congratulations to Team Yosi and whoever are the organizers and all the participations. It was really very, very nice to see such good level of presentation and sharing of knowledge.
Thank you so much, ma'am. Dr. Raghu has been a regular part of our series and always keeps teaching and mentoring us. Dr. Namrata is also here for the first time. Dr. Namrata, do you have any comments?
Yes, thank you so much, Ayushi, for involving me in this session. It was wonderful, and it was truly heartening to see DNB students presenting so well and covering really in detail the science and the history and everything. It was wonderful. Thank you.
Thank you, and special thanks to our mentor panel, Dr. Shruti, Dr. Anju, Dr. Rohit, and Dr. Narendra for excellent mentoring of the residents and fellows. Thank you, everyone. We'll conclude the session. Thank you, Manjula ji, for the seamless streaming. Thank you, everyone.
Thank you. Have a
Thank you.
Thank you.
Bye-bye.
Good night.
Thank you. Bye.
Good night. Thank you.